Gastroenterology. Let's see what we have done so far. As I mentioned, this is the 7th program. We started months ago. The first program was in October regarding the different aspects of IBS in IBD. Afterwards, on November, we talk about the reflux, eosinophilic esophagitis, followed by the reflux disease on December. For the new year, we talk about an interesting topic. It was really abdominal bloating and distension. Afterwards, achalasia, and the last one was about dyssynergic defecation. Today, we have a different meeting. We have friends all from the same university, which is the University di Bologna, and we are going to have 3 distinguished lecturers. As usual, our program consists of 3 parts. Number 1 is basic or translational science study presentation. Number 2, a clinical science study presentation. And number 3 is a case presentation. And you can ask your questions using the Q&A session at the bottom of your screen. And please join us asking the question. Okay, let's start with our first speaker, who is Professor Francesco Azzaroli from the University of Bologna. Francesco, thanks for joining us.
Thank you for the kind invitation to be here with you. For this first part of the webinar, I chose a recently published article by the group of Camilleri entitled, okay, can you see the full screen? Okay.
Yes, we can see. No problem.
Entitled Comparison of Biochemical, Microbial, and Mucosal mRNA Expression in Bile Acid Diarrhea and Irritable Bowel Syndrome with Diarrhea. So we all know that the basis for understanding pathophysiology of this disease is the enterohepatic circulation of bile acids. And this is a very complex phenomenon, tightly regulated at different levels, ranging from the liver, where biosynthesis of bile acids occur, going through the intestinal transport. And we all know that the vast majority of the bile acids, more than 90–95%, are reabsorbed to get back to the liver. So this is a very important step, because we all know that when an excess of bile acids reaches the colon, a number of events take place. And particularly secondary bile acids, chenodeoxycholic acid, deoxycholic acid, and also lithocholic acid, are able to induce several modifications in the enterocytes and the colonic cells, and they reaches these final modifications through usually an increase in intracellular calcium or the activations of several pathways like protein kinase C, cyclic AMP production, and so on. But the final results is clearly represented in this slide, which I took from a recent review by Giovanni Marasco. And as you can see here, there is an increase in the chloride secretion and the fluid secretion. There is an increase in the motility of the colon, and there is a reduction in the water and sodium reabsorption. All these is usually coupled to a damage to the transepithelial barrier and likely activation of receptors like TGR5. So there is a number of molecular events going on there, and they're not clearly all clearly understood. Now, the aim of the paper that I'm going to present is actually directed at trying to clear up more steps in these molecular events. I simplified the score of the demographic part of this paper. As you can see from this slide, the author started from more than 1,700 patients with IBS-D, And they tried to enroll the patients in basically two parts of the studies. A transit cohort, so patients undergoing transit studies that were carried out using scintigraphic methods, and a group of patients undergoing colonoscopy plus biopsies that were actually analyzed for mRNA gene expression. In this second group of patients, there were also 30 normal healthy volunteers that were used to compare the results. Now, of course, the difference between the two groups, IBSD and bile acid diarrhea, were expected. In fact, the difference in serum FGF19 or total fecal bile acids and the primary fecal bile acids in a random stool sample was clearly expected. And as you can see, in bile acid diarrhea, there is an increase in the total fecal bile acids with a clearly a significant increase in the primary fecal bile acids present in stool. So here are the results of these transit studies. And again, this is nothing really new. The results were expected. There was no significant difference with regard to gastric emptying. The small bowel transit here was evaluated as colonic percentage of colonic filling at 6 hours, while on the other hand, the whole colon and the ascending colon transit time was faster in patients with bile acid diarrhea. And this is in line with previous papers suggesting an increased motility in this kind of patients. A subgroup of patients accepted also to undergo rectal manometry to evaluate rectal sensation. No significant difference was observed between the two groups for any of the threshold tested. So basically, this tells us that the complex mechanisms regulating rectal emptying are likely not involved in the bile acid diarrhea phenomenon. And here come instead the mRNA gene expression studies. And this first table illustrates the results coming out from the analysis of the ELL biopsies. And as you can see, there is no significant difference here in terms of differential expression between IBSD patients and bile acid diarrhea patients with regard to the most important genes regulating the enterohepatic circulation of bile acids, FGF19, FXR, or ASBT. So no difference for those kind of genes. Instead, there was an upregulation in complement component C6, which deals with immune activation, suggesting likely inflammation going on there, and a downregulation of solid carrier family 44 member 5, which is a transporter of a number of compounds, including bile salts. Actually, the authors do not speculate much about the downregulation of this transporter, and they just stated that more research is going on the role of these protein. Much more rich are the results coming from the ascending colon biopsies. And this is a very rich table, but we can see, starting from the top of the table, that there is variation in the regulations of genes that are important for the barrier function. An increase in the expression of Claudin-2, which is like a marker of a leaky gut, of a leaky barrier. A downregulation of a polypeptide of GAL-NT15, which is important in the production of mucin. So this tells us that the barrier is compromised, and also that there is a reduced production of mucin. So this is in line with what has been hypothesized before. There is an increased activity of inhibitors of serine proteases and cysteine proteases. So these are likely to be a kind of defense against bacteria proteases damaging the mucosa. There is also variations of genes, upregulations in this case, of genes involved in the regulation of inflammation and immune response, both on the pro and anti-inflammatory side. And finally, there are also modifications of proteins involved in cellular transport, differentiation, or proliferations of cells, and of course, in this case, of the intestinal epithelial mucosa. So the interpretation of these modifications is clearly depicted in this figure taken from the paper that actually shows that how the inhibition of serum proteases likely to counteract bacterial activity, damage of the epithelial barrier, and modulation of the immune activations all support that the colon mucosa is undergoing damage and, of course, is inflamed. So this is clearly supporting this kind of interpretation. And finally, the authors also evaluated the microbiota, and they found significant differences between the IBSD patients and the bile acid diarrhea patients. They found a lower alpha diversity and a different compositional profile. So there is also, according to that, a modification of the ratio between Firmicutes and Bacteroidetes. So this tells us that the microbiota from bile acid diarrhea patients is different with the lower abundance of microbes, and the profile of the microbes is different. In fact, they found differences both at the phylum, genus, and species level. And among this downward representation of different genera, around 26 genera were down represented, and more than 60 species in bile acid diarrhea patients compared to IBSD patients. And among them, there was the Clostridia species, and particularly, which are involved in the bile acid metabolism. Now, the authors also performed a microbiota functional analysis, and the results are represented in the slide. And as you can see, the first two, decreased expression of bile acid thioligase and reduced sulfatases, are involved in primary bile acid metabolism. In fact, this is involved in the conversion of primary to secondary bile acids, and the consequence is that we found a higher percentage of primary bile acids in stool of bile acid diarrhea patients. And reduced sulfatases activity means that the levels of sulfated bile acids in stool rise up. And the sulfated bile acids have reduced secretory effects, particularly with regard to deoxycholic acid and chenodeoxycholic acid. So this should reduce the potency of these secondary bile acids in inducing diarrhea. There was also observed increased tryptophan metabolism to pynurenine, and this might lead to reduced serotonin production within the lumen. And we know that serotonin may actually promote motility. So this might be another compensatory mechanisms of these modifications of the microbiota. More difficult to interpret, and actually the authors do not express their idea very clearly on that, is the increased gamma monobutyrate and tyrosine synthesis and the reduced methanogenesis that they observed in this microbiota functional analysis. So I think that the results of this interesting paper regarding not only the transit, which is an expected result, but also the involvement of the immune activation and the genes involved in the inflammation control and the expression of Claudin 2 downregulations of protein involved in mucin production actually fit very well in the pathobiology of bile acid malabsorption. And of course, the importance of the microbial modifications, which might also in the future represent a therapeutical target, is something that likely needs more and more research and studies on that. And with that, I finished my presentation. And so I'm ready for any question that the audience might have.
Yeah, thank you, Dr. Francesco. While we are waiting the question from the audience, let me start. You are talking about the microbiota modification. Do you think that fecal transplantation might take a place in the future or as a potential therapeutic area for the bile acid malabsorption?
Well, this is an interesting question because fecal transplantation is really attractive in that case. And it might be. I'm not sure about the long-term results because fecal transplantation also in IBSD has not been always successful. So this is something that needs evaluation. This is because the modifications of the bile acids composition, I mean, elevation of primary bile acids and the increased bile acid content in the lumen is actually something that hits the microbiota because some microbes are more sensitive to bile acids and suffer the microbial control. So my guess would be that if the problem is upstream, I mean, it's a problem of the biosynthesis, for example, or the malabsorption, given too many bile acids in the colon, I think it probably wouldn't last very long. That's my guess, but it's only a hypothesis, of course.
Could you please stop screen your, yeah.
Let me.
Yeah.
Okay.
Oh, lovely. Let me ask you, is there any question, Giovanni, you or I have another one if you wish?
Well, I have a comment rather than a question. I've seen in the summary slide that you showed that there was reduced methanogenesis. I think that this is also very interesting because methanogenesis in the colon, at least to a lot of papers that were published in the past, is correlated to a reduced transit. So the speed is reduced with methanogenesis. So I think that this is very interesting when you correlate the results of the paper with the reduced transit in the colon. I think that this could be due both on the effects of the primary bile acids, but also on the microbiota that is reducing transit. I think that this is very interesting. And also all the data that you showed us regarding inflammation, I think that this is fascinating because it's an effect that probably is mediated by the increase in intestinal permeability that you showed in the paper, but also probably a direct effect of bile acids on immune activation. And this is very interesting, I think.
I totally agree.
So it's more a comment than a question.
Yeah, but if I just can add something, I totally agree with that interpretation. In fact, particularly secondary bile acids have been shown both in vivo and in vitro that are actually pro-inflammatory, while also the oxalic acid instead usually has anti-inflammatory activity. So this is certainly a fit comment.
Yeah,
I totally agree.
Okay, thank you. Can we continue with Giovanni Barbara?
Sure.
Giovanni Barbara, he's a professor in the University of Bologna in Department of Medical and Surgical Sciences. He's going to talk about he's going to give us a general idea about the bile acid diarrhea, and afterwards share an interesting recent study. Giovanni, thanks for joining us. As a previous president of ESNM, welcome.
Thank you. Thank you very much, Serhat. It's a pleasure to be here. And I will comment this paper that you see there, efficacy and safety of cholesevelam in the treatment of bile acid diarrhea. I will do that by putting the paper in context. In other terms, I will go through some background slides, starting from the history, because we must acknowledge that bile acid diarrhea is 55 years old now. This man is Alan Hoffman. We could say that he is the father of bile acids. He has been a great researcher in this field. He passed away a couple of years ago. He was 94 years old. And with these studies, he prompted the concept that in many patients that you see categorized here in different types, you can get this type of malabsorption. So type 1 is secondary, particularly those who have ileal problems, the site of reabsorption of bile acids, for example, Crohn's disease or resection in this part of the ileum, generates malabsorption of bile acids. Type 2 is the so-called idiopathic, and in this category probably fits very well IBS with diarrhea, in which many patients have bile acid malabsorption. And then there is miscellanea. Here you see many other forms, for example, cholecystectomy or gastric surgery, small intestinal bacterial overgrowth, and so on. The important thing is that we should consider that bile acid malabsorption is very common, more common than we thought, and affects around 1% of the population. So how can we diagnose bile acid malabsorption? Basically, there are several ways we can do that. Probably the best one is assessing bile acids in the feces. This is a 24-hour stool collection. However, unfortunately, is very unpopular, and there are no laboratories, at least in main centers, that do this type of bile acid assays. Then you can use the CCAT testing. This is a nuclear medicine test. You measure the retention of this bile acid that is linked to selenium-25, and basically the more you retain, the more you have the bile acid in the enterohepatic circulation, so the less you have bile acid malabsorption. And this is a test that is quite diffused now, particularly in England, also in Italy and in other countries in Europe. And the measurement we will see in detail in a couple of minutes. Then you can measure the FGF19 that is synthesized by ileal enterocytes and gives feedback inhibition of bile acid synthesis to the liver, and it's an indirect measure of bile acid reabsorption. Then finally, you can also measure this C4, which is a direct measure of hepatic bile acid synthesis. These last two tests are common and very popular in the United States, because in the United States, the CCAT is not approved by FDA. So it's the only way you can measure bile acid malabsorption. So this is the CCAT. On day 0, you administer a capsule containing tauroalcoholic acid, and this is marked, and you get the first acquisition right away, 5 minutes after the assumption of the capsule. Then on day 7, you get a second acquisition. And obviously, as we have heard from the presentation of Francesco, you have to reabsorb around 95% of the bile acids in order not to have bile acid diarrhea. So if you have a lot of retention, more than 15% is normal. If you have a retention that is between 10 and 15% of the capsule, then you have mild bile acid malabsorption, 5 to 10 moderate, less than 5 severe bile acid malabsorption. So if we compare the different tests that we have available, you see that the sensitivity goes down as we go from the CCAT, around 90%, go down to 85% with the C4 and 64% with the FGF19. Specificity is also going down from the CCAT to the other tests. Unfortunately, there are not many papers that validated these serum tests, including the C4. And this was one of the aims of the paper that I'm going to present to you. Bile acid malabsorption is very common in patients with IBS. Here you can see a study that was done in Sweden, and you can see that the more you have retention, the less you have bile acid malabsorption. So here you have the healthy controls. IBSD, obviously, as expected, have more bile acid malabsorption, as well as IBS with mixed bowel habit. IBS-C are comparable to healthy controls. And there is an inverse correlation between the retention of the CCAT with the colonic transit time. So this speaks in favor of what already Francesco showed us regarding the fast transit that you get in bile acid malabsorption. According to a recent meta-analysis, this is very common in IBSD patients, and about 1/4 of the total population of IBSD, according to this particular meta-analysis, has bile acid malabsorption. So this obviously enters with full title in the guidelines that are published now in the literature. And you can see here is one of the most recent published guidelines on IBSD and functional bowel disorder with diarrhea. You see, I would not go through the details here, but basically you do the assessment of the patients and see if you identify abnormalities, and then you go down, and in those who do not respond to conventional therapy and they have eventually severe symptoms, you may think to do colonoscopy with biopsies and enteroscopy or other tests, including the CCAT test to exclude the bile acid malabsorption. Why is important to exclude bile acid malabsorption in these patients? Because if you identify this, you have a good response to therapy, but also you can speak to the patients and tell them that you have identified a mechanism underlying their symptoms, and they can cure that with a specific therapy rather than going for symptomatic therapies. So speaking about treatment, again, the man that I showed you at the beginning, Alan Hoffman, also after identifying this patient, also he provided a therapy. This is cholestyramine. Cholestyramine was initially sold by companies to reduce cholesterol, which was a very weak drug in that respect, but also the side effect in this patient was constipation. So this is a resin that is able to capture bile acids and avoid the effects that these can have in the colon when they skip reabsorption in the small bowel. So here you can see basically the efficacy according to bile acid malabsorption severity. You get a higher response if the malabsorption according to the CCAT is less than 5%, you get 90% of response. Of course, these drugs have many side effects, including bloating, constipation, and other effects, and so they are not very good drugs. Cholestyramine is the first-in-class treatment for this condition, but there are other drugs, including cholesevelam and cholestipol, that can be used, even if they are not widely available. According to this uncontrolled study, about 50% of patients do not respond to cholestyramine. If you take those who do not respond to cholestyramine and you switch them to use cholesevelam, then you can get another 50% more or less response in these non-responders to cholestyramine. So for this reason, bile acid sequestrants enter in the guidelines for the treatment of diarrhea, functional diarrhea, and also IBS with diarrhea, even if the recommendation is weak to moderate. Why is that? Because the literature is not very good, is old, and there are not many papers on these treatments. So now coming to the paper that I was asked to comment, this is a paper looking at the effect of cholesevelam in the treatment of bile acid diarrhea. Here is the design of the paper. This is a randomized control, placebo-controlled, parallel group phase 4 trial of cholesevelam in bile acid diarrhea. How did they identify the patients? Basically, these were patients that were sent for bile acid diarrhea, for an hypothesis of bile acid diarrhea. They were 1,100 patients, more or less, and then these patients did the CCAT. And at the end of the story, just to cut it short, 168 patients with the suspected bile acid diarrhea were randomly assigned 1-to-1 to either cholesevelam or placebo. And these patients were also tested for the C4 that I mentioned before, apart from the CCAT that they did, basically all of them. The patients were between the age of 18 and 79 years old, and they all had diarrhea. And diarrhea was defined with these descriptions: 3 or more than 3 bowel movements, or 1 or more in the score of the Bristol-Stool scale that is defining diarrhea with the numbers of 6 and 7. The patients were treated for 12 days with the cholesevelam treatment, 625 milligrams, 2 capsules, 3 times per day, and the effect was assessed and the dose was titrated during the first 5 days and adapted to the patient. The primary outcome of the study was remission during treatment in days 6 to 12 of bile acid diarrhea. And the cutoff that was used in order to assess the patients with the C4 was the concentration of C4 more than 46 nanograms per milliliter. And the remission was defined as absence of above criteria for diarrhea during the treatment days 6 to 12. So here are the results, and this is the main slide that I'm going to show you. Basically, you can see that if the patients were defined having a C4 more than 46 nanograms per milliliter, or with a CCAT retention of less than 10%, in both cases, there was a very good response to cholesevelam that was significantly higher to that obtained with placebo. If you look at the data in detail, you see that the remission was achieved during days 1 to 5, so rather quickly if we used the mean total stool per day. So you see that the stool per day decreased only in the cholesevelam arm, but not significantly in the placebo arm. And the dotted line means the arbitrary setting of the remission that we defined before. And even better results you can get at days 6 to 12, while in the placebo, you never reach the remission. Similarly, when you use the cutoff of the Bristol-2 scale, 6 and 7 at the beginning, then you see that you can get remission at days 6 to 12 in the colesevelam arm, but not in the placebo arm. And similar results, I will not go into details, but is very similar if we use as entry the definition of bile acid malabsorption based on the CCAT retention of less than 10%. So according to these studies, according to the C4 definition of bile acid malabsorption, in the colesevelam arm, you get 64% of remission, 16% remission in the placebo, and this is statistically significant. According to the selection with the CCAT measure of bile acid malabsorption, you get 59% remission in the colesevelam arm, 13% remission in the placebo arm, and this is highly statistically significant. What about adverse events? Basically, colesevelam, like cholestyramine, has adverse events. Even according to the published literature, colesevelam has less adverse events compared to cholestyramine. But basically, you can see here that you can expect some adverse events, such as bloating, which is more common in the colesevelam arm, and constipation, which is basically an extension of the activity of the drug. So this is expected that if you use too much, then you can get constipated. Less expected adverse events, basically not much, but in some patients, heartburn can be seen more in the colesevelam compared to the placebo arm. So the conclusion of the study are that colesevelam was superior to placebo at inducing remission of bile acid diarrhea diagnosed with the C4 concentration greater than 46 nanograms per milliliter. So this study basically is a validation of the C4 that tells us that if we use this method to diagnose bile acid malabsorption, then you can predict also the response to bile acid sequestrants. Next, colesevelam induced remission in 2/3 of the patients, thus validating this concentration, but also telling us that colesevelam is a very effective drug in these patients. Inducing remission in 2/3 of patients, indeed, is of a significant clinical benefit and in line with the indication from previous non-conclusive trials. So this is an important paper, I think, and it's good to see that this topic that has been not very extensively studied, particularly according to novel therapies and well-designed trials, is getting attention nowadays. So with this, I finish, and I'll be happy to take questions.
Thank you, Giovanni. Shenjan from Turkey, she's asking an interesting question. Does having cholecystectomy affect the frequency of bile acid malabsorption in patients with IBS? Because, you know, we do not have CCAT, and the either C4 measurement is not common at all. In that case, having cholecystectomy affect the frequency of malabsorption in patients with IBS. What is the, or should we really differentiate the type 2 or 3, and what does it affect our therapeutic approach at all?
Yeah, this is a very good question. And I think that in certain conditions, for example, Crohn's disease or ileal resections or cholecystectomy, if you get diarrhea, probably you don't even need to test. You can go directly to treatment. So in this case, I think that the expected response to cholestyramine or cholesevelam in these patients could be very good, even without testing.
In centers, in countries without CCAT, which is pretty expensive, which one you suggest if you want to diagnose it, FGF or C4 or both?
I would suggest C4, even if there is a paper from Camilleri that tells us that if you combine C4 and FGF19, you get a better response.
Dr. Sertash is asking, what is the therapeutic time frame in such cases? How long we should put them on cholesevelam or cholestyramine?
Well, for life, I would say, if malabsorption is a chronic condition, there is a very nice paper that I didn't have time to show that assessed the long-term evaluation of bile acid malabsorption in patients. And you see in this paper that over a period of 16 years, if you repeat the CCAT testing, the results are identical. So this means that in those who have bile acid malabsorption, this is a chronic condition and therefore should be treated for life.
Well, guys, I drop because of the connection problems. Is there any question to Giovanni Barbara? Giovanni, could you please take?
Yeah, sure. I think that Serhat has problems with connection, so we can continue and we go to the next presentation that is from Giovanni Marasco, our department here in Bologna, and he will present a case of chronic diarrhea. Please, Giovanni, can you share your screen?
Okay, are you able to watch on full screen my presentation?
Yes, no problem.
Okay.
Good.
Good afternoon. I will present a case of persistent diarrhea. These are my disclosures. And we are talking about Marco, who is a young man working as a financial consultant with a stressful life, since he has to manage many clients. And often his meal is based on snack and he doesn't practice any physical activity. And he reports that he has been suffering from diarrhea, assessed with a Bristol stool scale of 5 to 6 and 3 to 4 bowel movements per day, flatulence and urgency since adolescence. He decided to release stress, organizing a trip in a tropical island, and during holidays, he developed fever and acute vomiting and diarrhea, which lasts 6 to 8 days, for which he took wide-spectrum antibiotics with initial symptoms improvement. However, since that episode, he has continued complaining persistent daily abdominal pain and bloating, diarrhea, which worsened if we compare with that reported in his everyday life with BSS 6 to 7 and 5 to 6 bowel movements per day and urgency. He asked to his general practitioner a visit, and the GPs prescribed stool analysis for ova, parasites, and cultures, which were all negative, and prescribed loperamide 2 milligrams on demand. Using loperamide, the diarrhea slightly improved, but abdominal pain persisted and bloating worsened. After 2 months of persisting diarrhea due to the symptoms persistence, he was prescribed rifaximin 400 milligrams 2 times per day for 10 days, followed by multi-strain probiotics for 30 days. Even in this case, diarrhea slightly improved with a BSS 5 to 6 and 2 to 3 bowel movements per day, but abdominal pain still persists. Therefore, the GP sent the patient for a gastroenterological evaluation. And after 6 months from the acute bowel infection, Marco reported his clinical history to the gastroenterologist with a previous appendicectomy, no chronic pharmacological therapies, except the ones prescribed by the GPs for the chronic diarrhea in the last 6 months, an history of depression in adolescence, and pollen allergy since childhood. The gastroenterologist prescribed a number of examination with a normal blood count, normal C-reactive protein, normal crapoleptin level, and negative celiac disease serology. Therefore, he finally diagnosed an EBSD with diarrhea because he applied the symptoms-based approach according to the Room 4 criteria with the minimal testing, including the blood count, the CRP, the celiac disease evaluation, and the fecal calprotectin. Since Marco reported recurrent abdominal pain at least 1 day per week in the last 3 months, the abdominal pain was, of course, associated with a change in the frequency of stool and associated with a change in stool form according to the Bristol Stool Scale. And all the criteria have been fulfilled for the last 3 months with a symptoms onset overlapping to the acute bout of infection that was at least 6 months before the diagnosis. And in this specific case, we can also have a diagnosis of post-infection IBSD. Therefore, the gastroenterologist prescribed a first-line therapy for IBSD, including a low FODMAP diet and ondansetron 4 milligrams 3 times per day. With this therapy, Marco reported a slight improvement of diarrhea with a Bristol Stool Scale of 5 and 3 to 4 bowel movements per day, but abdominal pain and bloating persisted. In the meanwhile, Marco did not report other digestive symptoms except for fecal urgency and episodes of fecal incontinence during night sleep. Anyway, he reported increasing anxiety related to the persistence of symptoms. Therefore, he came back after this first-line therapy for symptoms persistent for a second gastroenterological evaluation. The gastroenterologist prescribed colonoscopy mainly to rule out microscopic colitis, and at the colonoscopy they found a normal mucosa without pathological signs, and biopsies were taken in the ileum, the right and left colon, showing only a slight increase in intraepithelial lymphocytes in the laminar propria without pathological characteristics. For nocturnal symptoms persistent, he was prescribed a SECA test that showed a retention of 11%. That means that there was a mild degree of bile acid malabsorption. Finally, the gastroenterologist prescribed cholestyramine 4 grams 2 times per day with an initial improvement of urgency and diarrhea with a Bristol Stool Scale form 3 to 4 and 2 bowel movements per day, but there was also a slight worsening of bloating. You remember the presentation of Professor Barbara, and bloating is one of the main adverse events of the therapy of cholestyramine and cholecevela. In this case, however, there was a clinical response, so the drug was not changed, but cholestyramine dosage was titrated to 4 grams once per day in the morning and 2 grams once per day at bedtime, with a persistent improvement in diarrhea over time and an improvement in the bloating that was previously referred by the patient. So the take-home messages of this clinical case are that up to the 30% of patients with diarrhea predominant IBS have incidence of bile acid diarrhea determined by SECA testing. Bile acid diarrhea has also been reported in patients with post-infectious diarrhea, as in this case. And in patients with IBS and chronic unexplained diarrhea, the diagnosis of BAD should be considered and performed with SECA or other biomarkers when available. Otherwise, if testing is not available, a trial of treatment with bile acid sequestrant should be performed in all these patients. And thank you for your attention.
Thank you, Giovanni, for the lovely presentation. Let me start the question first. Do you think this bile acid malabsorption in a patient with post-infectious IBS is a reflection of the IBS?
There is a slight overlap. Actually, you know that in IBSD and especially in patient with IBS with diarrhea, there is a very deep dysbiosis, and the main results of the dysbiosis of patient with IBSD underlying also reduction in some bacterial strains like those with bile salt hydrolase activity. Therefore, it means that there may be a strong overlap between these two conditions, and that since the clinical symptoms and the clinical presentation may be the same, we often are not able to distinguishing among these two pathological entities.
Maybe I can ask a question to Francesco, who has a long experience in bile acids and also treating these patients with these drugs. Francesco, the dosage and timing of the treatment in these patients, because we know that sometimes also the palatability of these drugs is not very good, and interaction with the vitamins. So when should we give them the drug, and how do we titrate the dosage?
In my experience, I always start from the lowest dose and go up. And because my experience, many patients respond to just 4 grams per day. So I wouldn't go higher just from the start. I would titrate the dose over time. And usually basically you could administer it throughout the day, but in practice, most of the times, the most effective time of administration is the late afternoon of the evening. This is at least my experience. So this is probably has to do with the circadian rhythm of motility and the capability of the resin to capture many of the bile acids that are still there. So in my opinion, what I usually do is start with the lowest dose with just one administration of 4 grams per day, usually in the evening, and then titrate it up according to the clinical response.
Yeah, I also think that this is an important suggestion for people who start treating these patients to go up with the dosage, because it's quite common to see that patients get constipated right away. Other patients don't respond to very high dosages as well. So you have to titrate always the dosage. So this is a practical message that we might give to the audience. The other question that I have for you and for Giovanni as well, there are papers that suggest that the BMI is another important indicator. So people with high BMI and eating fatty meals may experience bile acid malabsorption. So what is the link between fatty meals and BMI and bile acid malabsorption?
It is known from studies from the 70s that the obese people have higher bile acid synthesis. So this is probably a pitfall also in the diagnosis, because C4 is usually more elevated in obese people. And actually, if the fat meal comes first or the obesity comes first, this is something that obviously needs to be elucidated in more detail. But it's a matter of fact that the obese people has a higher synthesis, and actually in the bile acid diarrhea subgroup of patients, for example, in IBSD, throughout all the papers you find that are heavier and usually a little bit older. So this is something that probably comes first. So my guess would be that the diet leading to an increase in weight, so overweight or obesity, ends up in higher synthesis and likely bile acid malabsorption. But this obviously has no scientific proof right now.
Yeah.
I have a question for Professor Barbara.
Yes.
Giovanni, in your opinion, are there some clinical symptoms that may justify performing the CCAT before other testing or as primary test in patients with chronic unexplained diarrhea? I mean, for example, those patients with a lot of diarrhea, with yellow feces, with a lot of urgency and so on. And how do you manage this kind of patient in your clinical practice?
Yeah, this is a very good question. I think that unfortunately, we don't have a very good clinical predictors of bile acid malabsorption. So we have to probably restrict this type of testing to patients that do not respond to conventional therapy, A, or B, those who have very severe and chronic symptoms. And I think that in these cases, probably you could get the best chance of getting a bile acid malabsorption. Also, the testing is obviously restricted to those patients that have the test available close to their hospital. I mean, you cannot send the patient to England to do the testing. So if you don't have it available, then you probably try to treat them instead of test and treat. So this is another option. Test and treat probably is not anyway the best choice if you have the test available, because this, as we said, is a chronic condition. Patients should be in a way instructed to use this drug for longer period of times. So basically, if you have a test showing that you have a malabsorption, it's easier to understand why they should be treated for a long period of time.
Thank you.
Okay, I think I don't hear from Serhat anymore.
I just attend, but Giovanni, but I have a bad connection. I think we should close here.
Yeah.
And that was as far as I can listen. It was a lovely meeting. And thank you to all, and hope to see you in the next one.
Yeah, thank you very much. Have a good day.
Thank you very much.
Thank you.
Bye-bye.
Bye.
Bye-bye.